BMJ has a paper that is very interesting and probably very controversial on perioperative beta blockade. Guidelines do not reflect the problems with the evidence from the decrease trials. And so to talk about this, I have one of the co-authors, Professor Darrel Francis, who is a cardiology professor, International Center for Circulatory Health, National Heart and Lung Institute at the Imperial College of London. Now, the European guidelines talk about initiating perioperative beta blockade. Okay, what do they say?
So they've changed quite dramatically in a few weeks ago. So in 2009, the European guidelines said that we should be very enthusiastic to use perioperative beta blockade to prevent complications of non-cardiac surgery. The problem was this recommendation was largely based on some trials which turned out to be, shall we say, unsound.
So the decrease family of trials.
Yes. They had some serious problems. So they were investigated after a whistleblower inside who was protected by Dutch whistleblower laws, which are very strong. It effectively forced the university to do an investigation. Their investigation revealed that of the 6 trials, 654321, decrease 6 was composed of patients who they were able to identify, but 97% of the patients had not had the stress echo and the operation that they were supposed to have had. So they were not really participants in the trial.
Right.
Sadly, much of the data for the earlier trials was mislaid by the time the committee went to look at them. So they were in a position of not really knowing what to do, because these 2 of these 6 trials, decrease 1 and decrease 4, are the strongest favorable evidence for initiation of perioperative beta blockade to prevent perioperative events. So if these 2 trials are not secure, the remainder of the literature, when looked at in aggregate, suggests a significant increase in mortality.
By about 27%.
Yes.
Which is definitely significant. So instead of a significant increase, the guidelines are suggesting that this is still a good idea to do, or have they changed that now?
So what has changed now is that the guidelines, and I must congratulate the authors, although I unfortunately said a few things which upset some people, and I've publicly apologized, and I take the opportunity to apologize again. These people work very hard, but it appears that there were over 115 people working on this, and there were 279 publications to go through. And I had said that perhaps some of them hadn't read all 279, and I was quite rightly slapped down by the European Society, because apparently they did all read it. They made a landmark statement for scientific integrity, because they said even though the decrease family of trials have not been retracted, I think there's been 1 or 2 retractions of minor things, the 2 key papers, decrease 1 and decrease 4, are officially still standing as valid science. And yet the guideline has said, we're not going to use them because we don't trust them. And that I have to congratulate them on, because they're the first people in the world who've been able to say this with authority. The problem is, although they didn't cite those studies directly, they used meta-analyses. And the meta-analyses turned out to have some influence from the decrease trials. Indeed, one of the meta-analyses, which was used to justify targeting of heart rate, had 6 trials in it. 4 of the trials had 0 events, so they contributed nothing. The remaining 2 trials were decrease 1 and decrease 4, the very trials that we were trying to stamp out from the literature. So unfortunately, they had produced a distillation of decrease.
So they've lowered the recommendation to this, right?
They've lowered the recommendation to 2B, which, as I understand it, in fact, I've done a survey to see if people know what things like 2B mean. And suffice it to say, this article is going to be peer-reviewed, but many people have only a shady ability to verbalize what Class 2B means. But it's not Class 3.
They don't catch the fact that 2B is very close to Class 3.
Well, Class 3 is for things that are neutral or harm people or kill people.
Right.
So one would think that things that are neutral or harm people would go in Class 3. The entire world literature, which is composed of one big trial and lots of small trials, suggests a 27% increase in mortality. So my thoughts are a 27% increase in mortality would entitle a therapy to be somewhere between neutral or harmful. But this is disputed.
Now, we're talking about the ESC guidelines. What about the American guidelines? In the US, what do we say?
So this is another landmark moment for two reasons. Because the American guidelines have worked together with the European guideline authors and have communicated. And the second thing that they've done, which is unique, is that they've subcontracted the entire work of analyzing the statistics around the reliable trials, and they developed something called the Evidence Review Committee of experts who are not linked to any of the trials, so don't have any conflicts of interest of that nature, and who've done a very systematic analysis of the randomized trials and left out the trials which we think are invalid. The funny thing is, the ERC concluded, as far as my reading of it is, and of course, you know, two countries separated by a common language,
yes,
who knows,
exactly.
you say potato. I think it says, and I invite readers to check, that perioperative beta blockade trial evidence consists of two trials, POISE, which shows a significant increase in mortality, and the other trials, which on their own have a similar point estimate to POISE, but a much wider error bar, so they don't contribute much. And if you put them together, it is still, like POISE, significant increase in mortality. And I believe they say we would need another reason to recommend it positively. What is strange is it appears that the guideline appears to be recommending it positively, or at least they haven't given it the neutral or harmful grading. And I'm not sure what influence they had that made them do that. They do point out that they spoke to the European Committee, so maybe some answers could come from there.
Yeah. So bottom line, where do you think, based on the available evidence, where do you think what role is there for perioperative beta blockade for non-cardiac surgery?
The thing that the trials, and we are at a scientific session, at a scientific congress, and so we have randomized control trials, and we know that they are needed because the observational data can be unreliable. Through no fault of anyone, it's just the nature of biases that may not be captured. And so the trial evidence, as it stands, indicates that perioperative beta blockade initiation in patients as initiated and used in the way it's done increases mortality. So I would say it is appropriate in any situation where that would be desirable. I just can't think of any.
Exactly. Well, the paper is in the British Medical Journal, and so I highly recommend that you take a look at perioperative beta blockade. Guidelines do not reflect the problems and the evidence from the decreased trials. And for Professor Darrel Francis, I'm Rick McGuire, CardioSource World News. I'm the executive editor. Thanks.